Association Executive Nursing is our episode topic. My guest is Amy Brown, Chief Nursing Officer at the Michigan Health and Hospital Association. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Amy, thank you so much for joining us today.
Thank you for having me.
Before we get into our episode topic, can you share a little bit about yourself with our listeners?
I have started my career as a nurse in Grand Rapids, Michigan, primarily in adult patient care, worked at the bedside, and then transitioned back to Lansing, Michigan, and started my career at a large hospital. And I worked there as an educator, and then almost every 3 years took a different leadership role, started as an assistant department manager, then a manager, then I was a director over 7 adult inpatient units. Then I became a vice president, and on March 18th of 2020, in a parking lot, I was promoted to chief nursing officer.
That's literally right when the pandemic started.
Yes, it is.
So we hear about pandemic nurses. You were a pandemic CNO.
Yes. Yep.
What was that experience like?
I think the one thing that was challenging is whenever you get a new job, I think everyone wants to start in this. They have their certain ideas of how they want to start. What does your first 90 days look like and things like that. And that is the one thing that it was truly, I tried to come up with plans of what I wanted my first 90 days to look like, but I don't think anyone across the country knew what their 90 days were looking like because it was basically day by day, everything was changing. A lot of it was relying on the people that I work with mostly to help guide the way of being in a new position. Luckily, I was in an environment where I had grown up. And so I had a lot of great people that I worked with. And honestly, I just tried to do the best that I could and make the very best decisions each time, thinking about how it impacts staff and how it impacts patients.
So thinking back to your early days as a nurse, can you talk a little bit about your first exposure to nursing and other health associations, your relationship with them, and how that relationship perhaps evolved over time?
My first exposure to different associations was really looking at my state association for nursing leadership, which is the Michigan Organization of Nurse Leaders. And really, I joined that when I was a new leader and started looking at how leadership across the state looks and what an association or an organization can do outside of your normal work area and how you can really make an impact. I think that changed the different associations that I became involved with, such as AONL. And then also AONL is part of AHA, which is the American Hospital Association, which then led me to get involved into my state association, which is the Michigan Health and Hospital Association. And during the pandemic, the MHA had calls with the chief medical officers. And I was at a board meeting for where I work. And I was sitting next to someone, and her name is Lindsay. She worked for MHA, and I was asking her what she did, and she said she worked in field engagement, and her role was to meet with presidents of the hospitals. And at the time, I knew that MHA was getting together chief medical officers, and I asked, why does MHA not get a group of chief nursing officers together? Why are they only convening CMOs? And she said, I don't know. That's a great question. Would you want to help me get them together? And I said, I would love that. So we sent an invite out to all the CNOs in the state of Michigan. And we started the calls, I think it was in early 2023. And we had almost every CNO in the state of Michigan on the first call. And so I think we walked away from that meeting thinking, and we even asked them, is this something that you guys want to continue? And they were all very much said, yes, this is something we want to continue. With the help of Lindsay, I helped create those meetings, and it gave us a great platform to convene with others. And then fast forward, after I left my previous organization, I was still meeting with the MHA, and they said, we are thinking about developing a chief nursing officer role. And is this something that you'd be interested in? And so one thing led to another, and I started this position on May 13th of 2024.
So you literally asked a question trying to solve your own issue that yielded itself into your current job.
Yes. Yep.
Wow, that's a really interesting story. What other involvement did you have in associations? You talked about MONL and AONL. Were you on committees and work teams and things of that nature? And what was that experience like?
MONL, I started as we had district directors, and then I'm still on the board. I'm a member at large. And we have different committees. We have an education committee membership. I think the one thing that was very eye-opening is when you belong to an association, a lot of the times it's your time that you have to put in what you want to get out. You can't expect others to just do the work for you. If you really want to make an impact, you have to give of your time, and you have to volunteer to help out putting on a summit or putting on a conference or doing webinars. And usually it's outside of your normal working hours. But I think it's also in that sense of giving back. I think we as nurses always know that we have to precept others, or we have to help grow that profession. And so I think associations, I admire people who serve in those positions because I know that it's a lot of work, but the amount of professionalism and the amount of connections that you build, it is just, I can't even really describe it. It's a great sense of belonging when you are part of an association like that.
Earlier in season 4, we talked with Audrey McCullough, who's a nurse entrepreneur, and she talked about her journey and how she pivoted from the bedside nursing away from the hospital and into basically a beyond the bedside transitions coaching role, if you will. What was that journey like for you to transition from the hospital environment and pivot to an executive role with Michigan Health and Hospital Association? You talked a little bit about how you got there, but the transition itself, what was that like?
Nick, that's a great question. I've been out of the hospital over a year, and it truly still is very much a journey for me. I worked in a hospital for over 24 years. I worked in a hospital, and hospitals as are very unique. They're open 365, 24/7. In fact, even this morning when I came into work, it was 6:30 and no one was here, and it was weird. It's just, and I said that to a coworker. I said, it's weird not to be so alone in a place because I'm used to being in a hospital where there's always people around. So I think it's the connection. I would say that I'm still figuring out the transition because I do miss being able to round on patients and having that huge team of nurse leaders that I interact with all the time. The one thing that I've been really doing is intentionally because I'm trying to kind of, how do I achieve both things? How do I still stay relevant and understand what's going on in hospitals? But also, how do I move into this different position of working in an association and having to not just work in a hospital? So, one of the things that I've done is I've tried to be real intentional about my visits. So, I get to visit a hospital across the state of Michigan, and I always ask for a tour. So that at least gets me back into the hospital. I always ask, I meet with the CNO and we have a conversation about what is working. What are your barriers? Are there any connections I can make for you? And then I love for them to show me a tour. And I always ask, I would love for your staff to tell me what they are proud about. And I think that really highlights the great work that they're doing at their site. And then also, what are their barriers? Because when I go back to my association, I want to share with them what the struggles in hospital are and what we can do to help them. So I guess I would say is I'm still figuring out what it's like not to work right at the bedside. I definitely miss the patient interaction. And I would say that I'm continuing looking to perhaps in some type of volunteer capacity to fill my cup with that type of work.
I'm sure you don't miss the 2 a.m. phone calls, though.
I do not.
Talk to me a little bit more about your role. What are your responsibilities? What's a typical day like? You talked about visiting, and that's a great way to fill your cup. But what's your role like, and what's your
Yeah.
typical day like?
At the state association, every hospital in Michigan belongs to the MHA. And the part of MHA that I work in is field engagement. And that's really, we go into the field or we go into hospitals and meet with CNOs, leaders, presidents. And really, it's my overall role is really how do I convene nurse leaders to seek input? Also, how do I disseminate best practices, drive positive change, and also thinking about how I do all that with a unified voice to really influence healthcare transformation. So, on a day to day basis, my day looks different almost every day, which I really like because that is similar to a hospital. So, depending on if I have a visit, I might be driving 2.5 hours to get to a hospital, and then I visit for, depending on where I'm at and what I'm doing, it could be an hour, it could be 3 hours. And then I have to drive back to my home. Or depending on how far away it is, I try to have set up a few visits at a time. For instance, Lindsay and my coworker, went to the UP as
Oh, that
well,
takes a
the Upper
while to get.
Peninsula.
Yeah, a long time to get up there.
There's 13 hospitals in our Upper Peninsula. And just to see, we weren't even able to see all of them. We stayed for a week and we were able to see about 6 of them. And we also convened, I had a dinner for some of the CNOs. And so some of the CNOs, even though they still drove an hour or two to come to the dinner, but it was closer than driving all the way to Lansing. I think, and then also I'm also part of I oversee our quality and safety division along with our chief medical officer, which is called the Keystone Center. And that started just in September. And we oversee the staff that are doing the work and we do things to address workplace violence. We do obviously anything with regards to safety and quality. We do a lot of work around maternal health. I'm involved in a lot of different meetings with the state, with the Michigan Department of Health and Human Services, because we talk about funding. And then I'm also involved from an advocacy and policy perspective. I meet with our policy and advocacy team to think about what is it that they need from me with regards to documents, looking at different bills that are out there. I am not a lobbyist. I don't pretend to be one, but oftentimes by just the two of us talking or the group and I talking, I can try to understand what they're trying to get to help hospitals so that I can then go back to the CNOs and explain to them, here's what's happening in the state level. Here's what we need to do to help protect our staff and our hospitals.
How does your role and or the Michigan Health and Hospital Association interface with MONL?
Yeah, so MONL is a separate organization. MHA has been trying to do administrative things for MONL, looking at how can we help with space or things like that. But other than that, they are two separate organizations.
Okay, so it's not the same relationship that
No,
AONL has with AHA.
no.
Okay. Talk to me a little bit about what healthcare is like right now in Michigan. What are some of the unique attributes to receiving or providing care in Michigan?
I know from our work together in the past, Nick, that it is no surprise to you that emergency rooms across the state of Michigan are still struggling with a few different things. And this is the front door to all communities, right? They come to the emergency department. I've been in quite a few emergency departments and I've seen the same thing. I've seen people waiting for care hours. They are also waiting for a bed, so waiting to be admitted. Sometimes it's because the hospital's full. Sometimes it's because the hospital doesn't have enough staff to open additional beds. And these patients are very sick. I think that definitely has changed over the years. The other thing that I'm seeing is obviously with regards to violence and how it impacts our staff. There could be violence from visitors, but there are also violent from patients. And I think that puts our staff into a unsafe situation where they're trying to take care of the patient, but at the same time trying to protect themselves. We really are trying to think of how can MHA help our hospitals? What can we do? And we recently partnered with Lawrence Tech University because we are going to do some serious research instead of just jumping at solutions, which I know we all want to do that. And many hospitals have already done that. We're going to really try to take a step back and look at the research to see what we can do to see what is it that we really need to do and spread. And so we're piloting this with 2 hospitals in the state of Michigan.
What advice would you offer for a nurse executive or nurse leaders that may be interested in association executive nursing when their time to pivot arrives?
Say to stay open. I think that whenever an opportunity presents itself, when I think about my previous leadership journey, there was never a time when I truly set out and said, I want to be this. It just so happened that someone said to me, Hey, Amy, like we always talk about that proverbial tap on the shoulder. Hey, Amy, would you like to try this leadership role? I think that you'd be good at this. And it was like, sure, I'll try this. And then it was, oh, I really like this. And so I think that to stay open to the possibilities of a lot of different things. And I think that also to make it your own. That is the great thing about sometimes this work is that there is not a true playbook. And so I think that you can get a lot of input from those that you're working with. And that's the first thing that I do when I talk to CNOs. What would you want this position to look like? What can I do to make this position help you? So I think that being curious is the best way to say is how you can really think about different things besides the traditional executive role in a hospital.
Do you have any outcomes or measurements for success? I know that when you were a CNO, you've got your quality dashboard, you've got your green and red lights that you don't want to, your red that you don't want to see, and the green that you do want to see. How do you measure success in your role?
It's funny that you say that because when I first started the role, I felt very much like I needed to see so much data. And so I think that there's a lot of different ways to measure success. For one, it's a brand new role. They've never had this role before. So I think I can't compare to past performance.
Sure.
So it's really truly about building what I want and what the members want. So I think it's about asking them when I'm doing my visits. I think it's about getting out to people. So internally, that's one of my main goals is how do I get to every hospital and meet with every CNO in the state of Michigan? At first, when I first started, I was a little bit too aggressive with its schedule, thinking that I was going to get to all these hospitals. And I'm also reliant on their calendar and when they can make time for me. So I completely understand that. So the other thing that I'm looking at is MHA has a strategic vision each year, 2024, 2025, and we have goals in there. And specifically, we have a couple goals called out for myself. And one of that is how do we help build this job and also recognize nursing? And how do I work closely with my clinical dyad, which is my chief medical officer? We traditionally have had multiple meetings and opportunities for physicians for professional development. And so now Dr. Roth and I are saying, what could we do to offer this for not only physicians, but also nurses? So we're working on, we have an annual meeting every year on Mackinac Island. And so we're
Great
working.
place to have a meeting as long as it's not in January.
Oh, no, it's in June.
Oh,
The
great.
end of June. It's beautiful.
Wow.
So anyway, that's one of the things that we're going to be doing this year is really thinking about how do we collaborate and have a meeting together for chief nursing officers or nursing and physicians and really thinking about that dyad model and how you work together. And that's been really nice being able to have someone in this role as a chief medical officer. He's been really able to say, this is what he found and this is what works for him. And so we meet frequently and we're actually, like I said, we're both co-leading the Keystone Center for Quality and Safety.
Association Executive Nursing has been our episode topic. Amy Brown, thank you so much for your time.
Thank you so much for having me.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.